Thank you for the opportunity to join you in Nepal, even if only electronically. I do hope that I shall be able to come back to Nepal sometime in the not too distant future. I've been asked to provide you a framework for the legal requirements and the national authority needed for deceased organ transplantation based on global experience. And over the next 15 minutes, I shall try and provide you that outline. So let us think first what it is that makes deceased organ donation different. Here we have the timetable for living donation, living donor assessment, assessment of the donor medical risk, discussion with the recipient, assessment of the recipient risk, recipient cross-match, and then we go to surgical retrieval from the donor, the transplantation of the recipient and transplant follow-up, and hopefully recording in a registry. There's nothing essentially different to a coronary artery bypass graft or some other operative procedure, except that it's two patients who get the operative procedure. But there's nothing in law that's different. There's nothing in the hospital that's different. There's nothing in the assessment that's different. It's when you move to deceased donation that you have to contend with substantially different issues. And the diagnosis of death, of course, is one, organ allocation is another. The mechanisms of combining a donor procedure with potentially multiple recipients. That's different. And of course, then tissue banking and tissue utilization is, of course, an additional difference. And for this, you need a national legislative framework. So let's look at what those critical issues are in a national framework. And I've given you four here, and we'll go through them one by one. Firstly, compatibility with the WHO guiding principles. The World Health Organization and the Declaration of Istanbul have been staring at this picture since the 1970s. Transplantation has good, the white angels, and evil, the black devils. And they are integrally intertwined. You need to stare at this picture a little longer to be able to see both and to understand that the picture isn't made up until you have both good and bad attached to this outcome, transplantation. The Declaration of Istanbul is a declaration by the major societies, the major professionals in the field, looking at what our ethical principles are as professionals for managing donation and transplantation. And the World Health Organization, stimulated by a number of countries wanting the World Health Organization to take responsibility, has set the national guidelines for what is required for deceased organ donation within each nation. And so they have 11 principles promulgated here on the 22nd of May 2010, reiterated in 2018 and more recently. And those are principles that have descriptions attached to them and which each nation must look to understand how they will identify their national operative procedures with the international norms. And these norms cover all of the processes from donation through to transplantation and the recipient. Well worth a read and understanding what it is that nations have agreed to uphold in this field. There are things that are not instantly thought about. All substances of human origin are potentially covered within a set of laws. Do you want to cover them all? Do you want to cover them in different laws? Hematopoietic stem cell transplantation and organ transplantation? Do you want to cover that at the same time as looking at in vitro fertilization and human reproductive law, blood donation, plasma donation? And then you have advanced stem cell therapies and human-derived drugs, all of which challenge law in one sense or another, but should they all be in one law or not? A national decision. Now, donation is a gift, and a gift is a voluntary, legally binding, and uncompensated transfer. Otherwise, it's a sale. So, donation of an organ is a gift, and that has important ramifications. It's legally binding transfer. The living donor or the family can't demand to have the organ back. They can't demand to be compensated with money or other valuable consideration. Otherwise, it wouldn't be a gift. And it engages altruism and volunteerism, and of course requires consent. And there are two primary legal models around the world: explicit consent, otherwise called opt-in, or presumed consent, called opt-out. And in opt-in consent, the donor and or the donor's family must explicitly consent by signing consent to donate. With presumed consent, everybody in the country is presumed to consent to donation unless they have specifically previously opted out. And there are proponents for both. And there are countries with explicit consent, here opt-in systems, as in Australia, for example. And here are a list of countries with opt-out. And I can tell you, it doesn't matter. People think that it's opt-out, it's going to be easier, you're going to get more donors. Well, the UK switched from opt-in to opt-out. Didn't get any more donors. And that's because when it comes to family objection in the opt-out system, nobody's going to proceed to donation. A family object to a loved one's organs being taken, they're not going to be taken in any of those countries. What it does is it changes the ethos of the conversation about consent with the family. I see so-and-so didn't opt out of donation. Therefore, we would be presuming that he would want to proceed to donation, versus an opt-in discussion about, do you know what the individual wanted in life? He hasn't signed on the donor registry. It changes the conversation, but it doesn't change the outcomes. So we come to the definition of death, and that has to be in the law. Because if somebody's not dead in law, when you start to operate, you've got a problem. So where do we start? And the place we start is that the function of the brain is irreplaceable. And actually, that is almost certainly where most laws are coming back to, having had a 50-year excursion. You'll see what I mean in a minute. So here in August 1968, a committee of Harvard Medical School, independent from transplantation largely, but not completely, you'll see Merrill and Murray both named, examined what a definition of irreversible coma would be, and that death was irreversible coma. And this led to the Uniform Determination of Death Act in the United States and mirrored in many other countries. And that act states that an individual who has sustained either irreversible cessation of circulatory and respiratory function or irreversible cessation of all functions of the entire brain, including the brainstem, is dead. Now, it doesn't define the medical definition by which those diagnoses are made, but it does describe what the diagnoses are to ensure that an individual is dead. And there are some definitions: loss of capacity for consciousness, unable to breathe, loss of brainstem functions. And there are a variety of tests, as you know, that can determine this. And it is permanent, critical issue. It is permanent. And that the diagnosis is made by individuals who are not conflicted. Some tests are used sometimes. This is a nuclear scan showing no blood flow to the brain. So in Australia, as in many countries, we now agree that there are two circumstances in which a person can die. It's whole brain death, not just brainstem death. But you can have irreversible cessation of all function of the brain of the person, or you can have irreversible cessation of circulation of blood in the body of the person. The traditional movie diagnosis of death. They feel the carotid pulse. It's not there. He's dead. And we have a variety of different state laws, but they all come down to the same thing. And that is essentially what most current legal frameworks state. But that law needs to be in the context of other national laws. Definition of nationality, the consenting framework, customs and excise laws and regulations, therapeutic goods laws and regulations, ownership and gift laws, and private healthcare laws and regulations. So it's not a standalone. It has to be seen in the context of the overall national legal framework. And in the end, there have to be some tiebreakers, some decisions that are made that whether something is or is not within the law. And in the end, the community has to trust somebody. Does it trust the ministers of health and justice, society leaders, the Ministry of Health, hospital administrators, committees, doctors, committees of doctors, independent doctors? That decision has to be made as to who makes final arbitration. So we come back to this model of what it needs to undertake deceased organ donation. And I've shown you here in green the things that are medical protocols. They're up to us as doctors. No legislation is ever going to cover those, nor should they. These are things that doctors do. They change with time. They are designed around each donor and each recipient and their medical protocols. And then you have regulations, which in many countries of the world are ministry regulations, who can do transplants, a ministry accredited transplant facility. How does organ allocation occur? A subject you'll be coming to discuss. What is the national allocation protocol? Who gets a donated organ once it's donated? And then there are a variety of protocols that sit outside, largely outside the transplant field, which need coordination. Intensive care protocols leading to the diagnosis of death. Organ donation organizations responding to intensive care units with potential donors. The surgical and medical teams, the HLA laboratory, the allocation program, and the national data system recording all of the information about transplantation. And finally, of course, all these things need community support. And so in most countries of the world, there is an organization of the government. You can call it what you like. I'll call it here the Organ Procurement Organization, which sits at the center of those issues which are of the public interest. It is responsible for maintaining the law and maintaining public trust an important issue in Nepal, particularly at the moment. They organize hospital donation processes, consent, retrieval, transport, data collection. They're responsible for defining the safety systems. How are you going to not transmit tuberculosis or strongyloidosis or rabies or some other encephalitis? What are the tests? What are the protocols needed? Somebody needs to make those calls. There needs to be education and training, IT systems and communication systems as it becomes a larger activity and more complicated. But education and training, particularly in the intensive care units early on, is critically important. And finally, somebody needs to be responsible for ensuring knowledge in the public to ensure public attitudes are positive, provide information and response to media. Thank you for the opportunity to talk. I hope that it provides you a useful framework.